Hello. Hello, good afternoon. I'm having some connection issues here at my place of worship, my place of work. So I am sorry if I'm not able to get this going for you. I apologize. I guess my name is Dr. Velma Scanterbury, and I am here with the Ask the Doctor session. I hope this is Dialysis Patient Citizens Educational Center, and I am here to answer your questions. Thank you, Maureen, for joining. This is Dr. Velma Scanterbury, and we are now doing a new session. It's at 4 o'clock on Wednesdays as opposed to noon, so that we can capture those on the West Coast and not be too early. So thank you for joining. Again, as I said, my name is Dr. Velma Scanterbury, and I am the medical consultant for Dialysis Patient Citizens Educational Center. And we're here to talk about all things kidney transplant or dialysis. So send me your questions and we will fire away with anything that you may be interested in hearing and things that you may want to talk about. I know in the news lately there has been articles about the patient who received the pig transplant, and I think they were able to keep it for a few months, but eventually had to be removed. But that is a good process, and so it still gives some inroads into being able to figure out what we need to do to be able to tolerate xenotransplant. And xenotransplant is when you take an organ from one species and place it into another species. And so you're taking a pig transplant and putting it into a human being. And that becomes, the body the immune system is different. And so it requires some extra medication to really get the body to accept something that is not like us, especially when it's from a different species. And so many moons ago, in the world of transplant, we had those initial issues with infections that occur when you get from one species to another. You also have rejection. So one of the things that we're, in terms of patients, there's a question there, sepsis explained. So generally our bodies oftentimes encounter things that become an infection. You may have an infection, say for instance, in your kidney. And so that becomes, let's say, a bladder infection. You may have a urinary tract infection. And if it's not treated appropriately, then that urine infection can get outside of that particular area where it is, and it gets into your bloodstream because that bacteria goes across the barriers. And so when it goes from a particular area into your blood, and it can then travel to different parts of your body, so that if you become septic when those organisms begin traveling around your body. So you call it sepsis, because if I do a blood culture in the midst of you having fever and chills and not feeling well, some people may not even have those symptoms, and I send your blood off for culture, your blood is going to grow out organisms, bacteria, it could be viruses. And so that whole cascade of your body trying to fight off this infection that's being spread around your body can be devastating to your overall system, because that infection can go from, let's say it was in your bladder, it can go to your kidneys, it can cause havoc on your overall system as your body tries to fight that off. So sepsis is when an infection is no longer contained and get into your bloodstream. It lowers your blood pressure, your whole body goes into a fighting mode, which can become devastating if those bacteria get out of hand. So you don't want to get septic, especially for those of you who are on dialysis or have catheters. Any infection in your dialysis access is going to get in your bloodstream quite easily. And so that becomes important to understand that skin flora from a catheter not having a clean site can make its way into your bloodstream, leading to severe illness and septic shock. Your body can actually shut down where you're no longer having good blood pressure, and your blood pressures continue to drop in those cases. So I hope that answers your question. So Nancy says a patient was told that there's too much calcium in the body to receive a transplant. So let's explain. So one of the things that happen as we have, as you know, get on dialysis, you have calcium phosphorus metabolism issues. So as your the balance is trying to keep your phosphorus low, so that your calcium that calcium balance stays normal. And so what happens is that with the inability to regulate calcium and phosphorus, because you are on dialysis, which is why you have to take your binders, you get a combination of deposition in your blood vessels, as a combination of calcium and phosphorus deposition. And so we see patients where your blood vessels are no longer able to be out. Normally we don't see your blood vessels on a regular x-ray because they don't normally contain calcium. Calcium is what lights up your bones, and your vertebral bodies. All those things have calcium in it. When your blood vessels show up, it's because there's calcium and plaque that have lined the lining or the inner portion of your blood vessels. And doing an X-ray or CT scan, we will be able to see your blood vessels outlined just by a simple X-ray. And all that means is that the calcium has accumulated inside the lining of your blood vessels. When we go to do a transplant, we're looking to see whether we can not cause or endanger your health if based on how much of that calcium is built up in the blood vessels where we need to place the kidney transplant. Making sure there's not too much in your heart. You have to worry about, will your heart get enough blood? Will your brain get enough blood? But if you have too much calcium built up, then you're going to have an issue with making those connections, because now your blood vessels are supposed to be thin and able to make an incision in it is now hard, and you can tap on it because now you have a calcium lining, and to cut into that is quite dangerous. You may spill debris that may go down your leg. You may have what we call dissection of the artery and separation of the lining, leading to a leakage and aneurysm, and so it becomes important. Some surgeons will say this is too far gone because I cannot make those connections between a normal blood vessel and your bad blood vessels because of the risk of peripheral vascular disease. And so if they feel that there's too much advanced disease, it's not so much just providing the kidney, but the kidney may not necessarily be perfused, but that advanced disease is also a sign that you have poor perfusion in other parts of your body, which may lead to, let's say there is a 50% decrease in the blood flow to that leg that you're going to put the kidney on. You're going to make that even worse. So you may run the risk of losing your leg and having an amputation, or even the risk of death. So depending on what they see on your scan, that may be something to be a hindrance to getting a transplant. So thank you so much for that question. Jim, you says I'm 8 years post-transplant next month, and you spent 8 years on dialysis before receiving your transplanted kidney. So congratulations in making 8 years, and we wish you another 8 years and beyond, keeping that kidney in good order and keeping rejection away or even infections from that standpoint. So great. One of your questions, Nancy, was about kidney swapping. What is the official name when donors give their kidney to someone other than the original recipient? We usually will say peer exchange. So there's a donor matching, peer exchange, or even chain it could be a chain reaction depending on how many centers are involved. We still call it a swapping of kidneys, but generally it's pair exchange. We're taking one kidney from one person and putting it into a different pair, and then that pair donor is going to be sending that kidney on to someone else. So yes, you are swapping kidneys out, but the pair exchange can also create a chain reaction where many centers can get involved and many different patients can result in getting a kidney from someone that is compatible with them that they may not know, but because of someone at the top of the chain decided to give a kidney to this center. So if my center received someone who stepped forward and they're blood type O, and they're interested in entering the pair exchange match rather than just donating someone particularly at my center, we put them into the donor pairs matching option, and the computer generates algorithms to see how many combinations from many different centers can be generated and how many can benefit from that one entry into the system that allows so many more other to receive a kidney. And that's how it goes across the country to then allow for benefit to many others. So it's a great system. And whenever most donors, transplant centers, whenever a donor steps forward, would ask them if they're willing to enter a pair exchange, which could benefit many more people than just given to one person in particular. So I appreciate that question. Why is fluid overload so dangerous for dialysis patients? Now remember, unless you are sweating or unless you have a way to get rid of that fluid, working out, any fluids you take in are going to stay in your body unless you have a venue for that fluid to get out, since you are not making normal amounts of urine. There's some people who are on PD, or peritoneal dialysis, and are still making 1,000 cc's a day, or even 500. As long as you have an exit for some fluid, you can control your fluid overload. But if you don't have a venue for fluid to exit your body, everything that you take in is going to put stress on your heart. So whether you're 5 pounds, just think of a 5-pound bag of flour. So you gain 5 pounds or 2.2 kilos. That is 5 pounds of extra fluid that your heart has to handle. And so for patients, the more fluid you gain without being able to urinate that fluid off, the harder your heart is going to have to work to move that fluid around. And that is what weakens your heart, leading to fluid overload, pulmonary edema. And so you have room to play if you're still making some urine. But when your urine output goes to 0, then you really have to be very diligent about your intake to prevent fluid overload and congestion. And that's why if you're doing home dialysis, then fluids in, fluids out can come off during that day, evening dialysis. If you're in center dialysis, you're only doing it 3 days a week. Then those days in between that you're not being dialyzed can be dangerous depending on what your heart is able to handle and what are your underlying issues from that standpoint. Because sometimes if you already have significant heart disease, then that can actually make your heart worse. And so what we see over time is that patients' ejection fraction, or the ability of your heart to pump effectively, will go down gradually the more years you're on dialysis. So your ejection fraction may be 60% when you start, but a few years in, it may be 40%. And the longer you are with more fluid gains, the less your heart is able to pump, and it becomes very flabby. Excuse me. And so you have less pumpability. So thank you for that question. Let's see again. I am Dr. Velma Scanterbury, and I am the medical consultant for Dialysis Patients Citizens Educational Center. And so we are here answering your questions at this new time slot, 4 p.m. on Wednesdays as opposed to 12 noon. And so we hope that we are able to have this communication. And those of you who are here, I thank you very much for joining. I appreciate your coming on, and tell your friends, and be sure to join Dialysis Patient Citizen. Go on the website, sign up to be an ambassador, and really continue to promote more education and learn more, find out how to make those best choices. And so Althea says, with the catastrophic loss we have had with kidney transplant, is it really the best choice? A person in Michigan got rabies. And I recently lost a friend after her transplant. Excuse me. Please help in getting second thoughts of going through it. I'm at the top of the list. Well, you have to, transplant is not for everyone. You do have to look at the risks and benefits of how you're doing, what your health is, and whether transplant is going to improve your quality of life based on where you are at this point. Certainly, survival after kidney transplant, long-term survival, is much better for the majority of people who receive a kidney transplant compared to dialysis. It is said that on average, 50% of patients on dialysis will die in 5 years. It's a bell-shaped curve. There are those who are 10 years post-dialysis and doing well. Depends on your age, depends on your comorbidities, whether you have underlying heart disease, whether you've had strokes, whether there are other issues that can come into play. And now you talked about, is it the best choice? It's an individual choice, and that is why there's such an extensive evaluation process to look at the risk benefits of that for that person based on age and what they expect out of life for the remaining years. Living on dialysis can be very devastating and deteriorating, but there are those who do dialysis and do it very well and are able to keep their complications to a minimum. A watching diet, being careful with their flu. The biggest thing is that patients, the number one cause of death for patients with dialysis is going to be heart disease. The number one cause of death for kidney transplant patients is still heart disease, because that becomes, the longer you stay on dialysis, if you didn't have heart disease before, renal failure will contribute to heart disease. So you have to keep your heart healthy in terms of your fluid volumes, minimizing phosphorus deposition, minimizing infections. So it is a job, and there are those who do it well. Getting rabies is very, very unusual. It depends on, maybe, the question is, was it, excuse me, due to the donor? Did the donor have a history of being bitten by something that got transmitted? Or was it that we're also immunosuppressed, so that as a recipient, was there something there that came to the surface by being immunosuppressed? We asked patients, for instance, if someone had TB multiple years prior to coming to a transplant. It's important to know that, because viruses live dormant. And now that you are immunosuppressed, for many patients, if you have a history of TB and tuberculosis and didn't tell your transplant program, then that, with all the anti-rejection medicines, suddenly your protection is lost, and now you can, that TB bacteria can come to the surface, and a patient can develop devastating TB after the transplant. Not that they caught it from someone else, but because their body's immune system had been keeping it in check, and now without that immune system being vibrant, you are now allowing things to surface, which is why we give medicines against viruses, because we know we have those viruses in our system, but they can surface after transplant. So we don't know the details of that one. I recently lost a friend after a transplant. We don't know what her underlying conditions were. Was the heart healthy? Was it due to rejection? Was it due to infection? There's details that are often unknown to us, but we see the devastating end of it. So when patients get education about transplant. We go through all the possible complications. We let them know about things that may occur, and they are often afraid, but we want them to know things up front. Transplant, as Nancy said, changes lives, and we want to be able to, you don't want to be afraid. We can go outside, or I can go outside and get hit by a car and be killed tomorrow. But it doesn't mean that I should be afraid to go outside, because at some point something good or something bad may or may not happen. But you have to be encouraged, because we have to think about what are the benefits of transplantation, getting off dialysis. If we know that the risk of death is greater on dialysis than transplant, then we wouldn't be doing so many transplants. We wouldn't have thousands and thousands of patients who have survived many, many years with a transplant. Fortunately, there are going to be those who don't have a good outcome, and we want those to be minimum. Unfortunately, when you see other patients who succumb to the complications, we get discouraged. But you have to have hope. You have to be honest with your transplant. And I try to be honest with my patients in terms of saying, well, sometimes this is not for you, depending on the complications that you may suffer after transplant, depending on your age, depending on how your heart's doing. So all those things become important to understand, and no two patients are alike. I can take two kidneys, I put them into two separate recipients from the same donor, and each one of those can have a totally different course, because your immune system is totally different from somebody else's immune system. So we want to thank all of you who have joined today. We want to encourage you and realize that, yes, there are going to be those bad outcomes, but they're minimum. So we want to press forward and always see that there's a positive side to all those. As Nancy's 14 years post-transplant. Yeah, there are those who are 20 years post-transplant. Sometimes that longevity cannot be obtained on dialysis, but it can. I've got a guy who's 20 years on dialysis. But unfortunately, by the time he came to transplant, his blood pressure was so low from having heart failure that he could not really undergo a transplant. So you do have to realize that there are going to be consequences on either side. Can you explain why I felt so lousy while doing peritoneal dialysis? Everyone else that I knew who did it said that they had much more energy and got around better, but I was the opposite. I had to stop only after 18 months and return to in-center hemo. And again, like I said, some people, we expect patients on PD to do better, but you may not have enough clearance depending on your size, how much you can hold, and whether your peritoneum is able to filter effectively so that you are getting a good effective dialysis. And it doesn't happen with everyone. There are those who may have not enough surface area to be able to effectively dialyze by PD, and so you're not achieving a good outcome, and so it's not working for you, depending on whether the surface of your intestines. So I've seen many patients who I thought should do well on PD didn't do well, and you feel lousy because you're not getting adequate clearance across your membranes in your peritoneum and around your your intestines, which work to try to give you the exudate. So yes, you don't have that diffusion capacity that optimizes your ability to dialyze. So unfortunately, there are those like you who don't do well on PD and have to switch over to hemo, and it's very unfortunate. But there's always the option of doing home dialysis, which allows you to minimize your complications of hemodialysis to do better, because really it's about being able to cleanse your body on a more frequent level than every other day, 3 times a week. If you think about the fact that we eat 2 to 3 meals a day, and we expect to go to the bathroom to be able to get rid of those waste products. So now you're holding on to those waste products for 2 and 3 days before you're asking the machine to cleanse your body. So definitely unfortunate, but hopefully you're on a better path and we'll continue to do well on hemo, but also make sure that now you're much more at risk for fluid overload, because now you're doing your dialysis times are less frequent. O positive, the worst. It's hard, and I'm on 3 transplant. Yes, they're absolutely the most common blood type is O, and so the O list for those waiting is tremendously long compared to O and A are long. O is usually longer than A, but those are the common blood types. While B and AB are less frequent, so those patients tend to get transplanted in a less time frame than O, but it also depends on the number of donors that are rare blood types in your area. So yes, you're competing against many more people at as O blood type, and 3 years, depending on where you are in the country, is not very long. There's some transplant waiting times, such as New York, which can be 10, 12 years waiting for a kidney transplant, which is why we encourage people to multi-list and find other areas that may have shorter lists that would allow you to get transplanted within 5 years. But for O lists, trust me, you're 3 years, you are not anywhere compared to many of the patients that I have seen. So continue to hang in there. And you said you're on 3 lists, which is about, this is what you want to do. So I appreciate all your questions, and we're coming to the end of the hour. Yolanda, I appreciate you encouraging everyone to join our community of patient ambassadors, and to learn more by going to the website, Dialysis Patient Citizens, dialysispatients.org, and you can learn more about end-stage renal disease. You can learn more about kidney transplant. You can learn more about how to eat nutritiously, and also encourage others who may be on dialysis that may need encouragement and may not be getting the answers they need. I don't have all the answers, but I'm here to, if I don't have it, I'll research it and bring it back to you. So thank you all so much for being here. And I appreciate you continuing to follow and stay abreast of any new developments. And we'll see you again next month. Take care. Be well.